All right, guys, Laura is going to give us our talk today. We picked a super practical topic to knock out, and then I have it recording so that we'll be able to save it to the YouTube page. So I'm going to go ahead and mute myself. Thank you, Laura, for your time.
Thank you. All right, guys, this is a lot of info. We're going to try and cover wrist and hand injuries. And if there's anything along the way, stop me. It can be tedious. Of course, I have to be able to start it. There we go. All right, so we're going to start out at our fingertips and work our way back. Just knowing the parts of whatever we're talking about is always important. And we are going to talk about the different joints. So when we start out with a hand examination, it's really important for history to know what their dominance is, what their sport or work is, and hobbies. Hobbies is one that people often don't think about, but somebody is a knitter or something like that, or a woodworker, and they're doing a ton of stuff with their hands. That's super important. And then, of course, knowing about their tetanus status for open wounds and lacerations. When you involve the finger, there's a lot of nail questions that might come up. I always think of if it's more than 50% of that nail bed that shows the bleeding under the nail, you are more likely to lose a nail and you're more likely to have a nail bed injury. The other thing is that a lot of pain can be due to that blood under the nail. So you might want to just release it, and I'll show you how to do that. And then all the other testing like we would normally do. You want to know your nerve distribution. So when we're talking about the hand, it's really important because as you can see, there's parts of it that are like your thumb can be half of one and half of another. And same thing with your fourth digit. So, it doesn't take enough just to be like, oh, do you have numbness or tingling here? You want to make sure you know where it is, and you want to be able to use something smaller to check and see on either side. Motor hand exam. I do this almost I mean, tons and tons of times. Someone has a neck injury, someone has an elbow, a shoulder, a wrist, a hand. It's the most distal form of the median, radial, and ulnar nerve. There are different ways to do it, but these are kind of the easiest ones. So thumb extension. With the radial nerve, you've got your pinching together your thumb and your pinky for median. And then the ulnar nerve is a piece of paper is a great, easy one to do it. Looking at the different levels of your finger flexion. So you want to look at the deep and the shallow, or the superficial and the profundus. Actually, in opposite order, profundus is deep and superficialis is the superficial. So, the full finger holding the other ones down versus holding down the PIP joint and flexing it for the deep can be very important to tell whether or not there's any tearing of the ligaments. And then this is how we reduce the pressure for the hematoma, the subungual hematoma. If you just take an 18 gauge needle and you just twist it on top, that can break through and release it. You don't need to have any sort of special tool. You don't need to heat anything up. A needle is sterile and it's sharp enough that it should go through, and you do not need to put a lot of pressure down. This also applies, of course, to toenails, and then it's really important to realize like the nail bed is a living structure. And if that gets ruined, you're going to have either loss of your nail and not growing back. You're going to have a ridge of the nail or part of the nail that doesn't. So it's super, super important to make sure that when there is an injury to the finger, that the nail, and if the nail is gone, that something sticks in between that little hook part of the edge of the nail bed so that it can continue to live and recreate a nail coming out of it. Oh, and one other thing on that, if the nail is off, you want to suture the nail down on either side so that it stays in place. All right, we're going to shift into some injuries of the distal finger. So mallet finger, I'm sure you've all seen this already. Less common in pediatrics, but in adults, we see it all the time. It can happen from just putting on your pants and jamming it, as somebody reaches down to grab it. It doesn't take a lot if you get it in the right position. And can be a piece of bone or it can be soft tissue. So the x-ray can be very helpful to tell you whether or not there's bony involvement. But if there's no fracture there, that doesn't mean it's not torn at the tendon. If they cannot actively extend their distal phalanx, that suggests rupture of that extensor tendon and needs to be treated. The best chance to treat it is right at the beginning. The longer they go without treatment, the harder it is for it to heal. So treatment is an extension splint. And you can use a stack splint. You can use a figure of eight splint. I don't think I have those pictures in here. I should get those. Anything you can put an aluminum splint on the dorsal surface and hold it out straight. The most important part is that they do not bend it for 6 weeks. So you have to make sure that the patients understand it is it's like having a cast on that you cannot take off. I will bring them back at 2 weeks just to clean their finger and to check and make sure that they're not taking it on and off. I say, show me how you take this off. And when I'm doing that, I'll have them put their finger down on a hard surface, push down against it, slide the brace off, and we'll clean it. And then we slide the brace on and back, tape it back on. The other thing is they can pour rubbing alcohol over their finger while the brace is on, and that can clean it too. Surgical treatment for these, if there's more than 50% of the bone, then it really becomes something different than a mallet finger. Now you're really, the whole distal phalanx is not being supported, and you have interruption of that joint, and that is a surgical consideration. A jersey finger is the opposite the opposite side. So instead of it being an extensor tendon, it's the flexor tendon, and you basically get to where you cannot bend your finger. So, this is a surgical treatment because it will not heal back. You can't splint it. You can't do anything. A lot of times, the tendon will ricochet back, and depending how far back it is, it becomes harder to fix. Just because you have to pull it through all the different pulleys. So moving back to the PIP joint, again, these joints seem so small, but they're really complicated. They are congruous joints, so you've got concave on one side and convex on the other, so that they match each other. There are stabilizers on either side, so you've got the volar side, you have the volar plate, and then you have your collateral ligaments, which help keep things side to side. And then, of course, when you load that finger, you're pushing down a convex onto convex on concave. And so you're creating stability by the shape that's there. So all of these work together, and can be obviously helpful in normal function, and with tears cause abnormal function. So when you dislocate, whether it's a volar dislocation or a dorsal dislocation, is super important. So most commonly, you're going to have a dorsal dislocation, and then we worry about the volar plate and the volar aspect of it. So first things, and actually this was the first thing I did as a fellow. I was on the Browns sideline and we weren't supposed to touch the players. And this guy came off with a, dorsal PIP dislocation. I was like, I can't just sit here. So you want to recreate the injury. So you're going to basically have a little bit of traction on it. You want to have your finger on both sides of the middle phalanx, bend it, pull, and then counter pressure. So, in all reductions, you're basically recreating the injury, causing traction, and then extending the injury, or the opposite direction. And the first time you do it, meaning the first time on this injury, not the first time you as a person do it, is the best chance to get it. The more times you try, the harder it gets. So you really want to be just aggressive and do it. The reason that the Browns don't like us touching this is because this can happen, right? It can break when you dislocate it, but it can also break when you're reducing it. So you want to make sure you're using proper technique and being aggressive enough, but not being, overly so. So after you reduce it, this is an important, you can visually see that it is in place because there's no longer got that big lump, but you want to make sure there's not a V sign. So when you get a lateral view, and a lateral view is super important, you check on the x-ray. So for example, on this finger here, we can see this is a very good lateral because you can't see both condyles. If you look at this joint, you can see the shadow of one condyle and the shadow of the other, so you know that it's rotated a little bit. So you want a good lateral view, and then you're looking to see if there's any opening on that dorsal aspect to suggest that the volar plate that connects these two here is intact. If it's intact, you're going to have congruency. A torn volar plate is going to cause that to be open, and that requires you to have a different treatment. So with that volar plate injury, you want to make sure that you are keeping them aligned and in place and congruous. So you basically want to put a splint in it and resting extension for 1 to 2 weeks. I misspoke there. It's longer than that. When generally you want to protect the joint for 3 to 4 weeks, especially with buddy loops or whatnot. But if you've got that volar plate injury, you need to have that healed, and it's going to take it's going to take 3 or 4 weeks for it to be, and you want to check it. So they can return to play with things on, but you really want to have it resting in extension as long as you can to try and get that volar plate to heal. And I follow those with not only physical exam, but with x-ray. So complex dislocation just means that it's bayonets and you can't get it back down. You might have some skin disruption, but generally these are open reduction if they're overlapped that much. So depending if there is a fracture involved would determine the treatment as well. So commonly you're going to see a small volar plate fracture, but if you start getting a fracture that's involved more of the condyle, those need to be treated and generally referred surgically. So if there's more than 30% of the joint involved, those are usually unstable and a surgical referral. If you cannot reduce it concentrically and you cannot get a brace to keep it there, those are a surgical referral. And if it keeps going back and falling back into dislocation, those are also. And of course, any open fracture. So a volar dislocation is a central slip injury or can cause a central slip injury. So those you want to splint an extension 5 to 6 weeks with the DIP free so that they can flex there. And again, if there is a fracture, they are generally a surgical referral. These are less common, but they do happen. So what is the central slip? So when you look at the finger, we talked about the collateral ligaments, keeping things side to side. We talked about flexor tendons and extensor tendons. The central slip is basically an area that the extensor tendon goes through the hood of the extensor hood. If it is torn, what happens then is that you've got your lateral bands that fall over and they just force the finger to go into flexion. So this bottom right picture you can see, it basically doesn't hold those lateral bands up so that now that it's bent, you've got your finger wanting to stay flexed. And that's what causes a boutonniere deformity. Sorry, this is out of order, but where'd it go? So one way you can test that central slip is with the Elson test. So I generally will just have them put their hand on the edge of the table, flex their finger down, and then you have them resist their middle phalanx to push out against you. And then you check to see whether or not that distal phalanx is able to move passively. If the DIP can be passively flexed without resistance, then it's intact. If you cannot, that shows you that that central slip is torn and those collateral bands are pulling up or extending that DIP here. So this is one of those tests that is good to practice. Again, sometimes if I'm in with a patient, I'll sit there and kind of do it to myself real quickly beforehand. Once you do it enough times, it makes sense. There are other tests too. So a positive tear test would be to passively extend the PIP and unable to flex the DIP, or having your MCP at 90 degrees, so flexing your finger, and then not being able to extend the rest of your finger to within 15 degrees of full extension. So again, if you miss a central slip tear, it causes this volar subluxation, so the falling off of those lateral bands. It bends the PIP joint, and it extends the DIP joint, which causes you to have a boutonniere deformity. So when you see a boutonniere deformity, it's really important to determine, is this because it is from a central slip tear, or is it more of a flexion contracture? So again, that central slip rupture causes the triangle ligament to tear away from the lateral bands, allows those lateral bands to come over to the side and pull it into flexion and extend the distal phalanx. So this is, to treat this, you are using an uninterrupted extension splint for 6 weeks. If it's really old, you can try to work on the flexor contraction and then do the extension splint. They are less likely to heal well, but you should try it first. And then the other thing is to differentiate is this a pseudo boutonniere where you basically have a flexion contracture that is causing the flexion at the PIP. And those you treat with progressive stretching, with dynamic splinting, but your DIP motion is normal. So a boutonniere has an issue at the PIP and the DIP because of a central slip tear, whereas a pseudo boutonniere just has a flexion contraction at the PIP and does not have the central slip tear or a DIP problem. So switching on to tendons, when we're looking at these, if the profundus and the superficialis are torn, you don't have flexion at either, right? There's nothing, you can't bend it either way. One thing that we will see is, especially in rock climbers, is you'll see kind of injuries that involve the different pulley tears. So when we look at the anatomy of how you bend your finger, each joint has a pulley there, and they're numbered starting proximally going to distally. So at the MCP is the A1, and then as you move out, they're kind of further out to A5. A2 is the profundus and the superficialis. A4 is only the profundus. So as you see where they can bend and not, you can tell which pulley it's at. So we see these disruptions in rock climbers because of the way they actually climb, but you can see them in other things too. But basically it's a forced contraction, and then you'll get a tearing, sorry, I can't find my arrow, a tearing at one of these pulleys, and then you might see bowstringing of the tendon as it goes across. So here they're showing a partial tear here, and then it's sort of bowstringing along. You'll get tenderness or pain along the flexor sheath. You might lose your DIP motion. You can actively flex it, but it hurts. These you want to treat with immobilization rest. You'll see climbers that tape their fingers to kind of support that pulley and relieve stress. And that, is kind of proactive and preventative, but also helps once they've had injuries. More commonly, we see trigger fingers. So that trigger finger, I like to draw like a fishing pole with and I'm very artistic, so I'll do like a line with some holes and then showing your fishing line coming in and out. And the popping that they're feeling is that swelling of the tendon as it's going through the pulley. And, generally, I always think of that A1 pulley down as the MCP joint. It's a little bit proximal that you're going to feel that bump because that's where the swelling is on the tendon, rather than you're not really feeling the pulley. But they're going to have a catching or triggering sensation. You might get stiffness and pain that's worse in the morning. And sometimes these can be treated with cortisone injection, a night extension splint, and then occasionally release of the pulley surgically. These are one of my favorite things to treat because people just feel so good when you give them an injection. You'll have people come in and they'll have been using like a popsicle stick or something on their own to extend at night. When we look at the thumb, we all know the thumb is a little bit different. It only has a proximal distal phalanx. It only has an IP joint. And the MCP is very significant. So with our thumb, what makes us opposable thumb people is the ability to pinch together at that MCP joint. The ulnar collateral ligament is the key component that allows us to maintain that, because it is not a direct flexion. You've got a flexion and then there's a radial force that the ulnar collateral ligament has to be present to sustain. And if it's not there, then what happens is your thumb just kind of falls off radially, and that's why that is a more important ligament than other ones. So it's really important to check that. The biggest issue when it's torn is that it does lie deep to the adductor aponeurosis, and so sometimes you can get that aponeurosis to flip underneath the ulnar collateral ligament when you tear it, which is what's the stentor lesion. So it's important to check, your radial collateral, your ulnar collateral, your roller plate, your flexion, your extension, and your strength. But it is also very important to just check the ulnar collateral and make sure that's not injured. So usually when we see a thumb dislocation, it's a little bit more difficult than a finger dislocation. And I guess difficult is the word. It can be more have long lasting effects. So it's usually dorsal. We usually see a volar plate disruption. And in the simple form, it can be reduced and everything goes back to normal. Usually though, what we'll see is that there can be a complex component to it with the difficulty of reducing it, or you might have the difficulty being because the proximal phalanx is dorsal to the metacarpal, or that you get that interposition of the sesamoid or the volar plate. And so those are surgical. I don't know if any of you have seen them. Thumb dislocations are less common, but they do happen. And I think people get really stiff with them, and we have to be very, very cautious when you're reducing them and checking, everything like everything else. But they just tend to be a little bit more significant due to all the collateral support. So with a simple thumb dislocation, you can use a hematoma block. I would avoid traction, just push on the palmar aspect of the metacarpal head. And it's usually stable because of all the different components involved. But these we protect in a thumb spica with mild flexion at the MCP, so you don't get stuck in extension. Getting flexion back is the harder part of motion for the thumb. We talked briefly about the ulnar collateral ligament, but again, the most important part is that we check the integrity of it. If you can't check the integrity of it because there's too much going on, it's too sore and you can't get a good exam, you want to bring them back and protect them for it until proven otherwise. It's usually a hyperextension with a radial deviation. The Stentor's lesion I mentioned makes it difficult because the ulnar collateral ligament cannot heal because the ligament is outside the aponeurosis, so it cannot connect back down to the bone. These can be hard to find, but if you have a complete rupture, that's when you're worrying about it. Partial ruptures, you can't get open enough to have the ulnar collateral to pop out because it's still connected to something. So this is the way you examine it. And for me, I feel like the more I do these, the better I've gotten at it. So like everything else, do as many normals as you can so you can feel it. If you're unsure what you're feeling on someone, they hopefully have another side to check. Side to side should be similar unless they've had injuries in the past. So you want to make sure it's less than a 10-degree variance on side to side. The checking them at different angles of flexion can be helpful because as you flex it, you're going to reduce that volar plate aspect or contribution of it. So if there is a fracture involved, you may have a complete rupture. And so that's something that you might actually surgically refer. And if there's any displacement of the fracture, you need to refer that as well. You can image these with ultrasound or stress radiographs or MRI. I feel like with the ultrasound now, it's really helpful. If you can get, a clear view of it completely torn, then you're going to refer it. Certainly, if you see a stentor lesion, you're going to refer it. and it just seems to be easier to do, and it's in office than the MRI, but the MRI is available. So treatment, 6 weeks in a thumb spica splint. There's some debate over this because, you don't want them to get stiff. So some people will treat a reliable patient with a removable splint that they can do gentle range of motion of your MCP and your IP. I often do the first 2 to 3 weeks in a cast, and then I change to an Exos and have them remove it for range of motion. That way I kind of have eliminated the unreliability the first couple of weeks, but then allow them to get the benefit of motion after that. And then do protect them for a while. The younger that they are, they do well, but I do use, and I think this is different than some people, but I do use a forearm splint, not a hand-based thumb spica for the original few weeks. So we're going to switch down into the wrist a little bit now. So gymnastics, very common to see, or it's really pretty much only gymnastics. I can't think of any other sport really. I guess cheer, which is similar, that you get that repeated impaction on the dorsal aspect. So dorsal impaction syndrome is just repetitive, and it's oftentimes bony tenderness. And then the soft tissue capsular tenderness. The repetitive extension and that sort of more than the body can handle load causes an irritation in that dorsal capsule and stress reaction in the bone. I treat these with a brace. If the person is non-reliable, I do cast them. And with open growth plates, we treat them a little differently. So we'll talk about that in a second, but you rest until they're pain-free with activity. They do, and I haven't used these in a long time, but DonJoy used to make an extension blocker brace so that you could get people back so they could get mostly almost to 90 degrees, but not fully. And it would block that last end part. And it would help people get back sooner. I think that, almost we're kind of missing the boat on these if we're doing that. Like if they're not in a professional sport, we kind of almost need to treat the problem instead of just giving them something that's not changing what's going on. So the extension blocker brace, I don't even know if anyone's ever used one. They're not as common as I used to see. And again, correct the mechanics. And oftentimes, if they're doing something, if they're not extending at their elbow, at their shoulder, maybe they're having to overcompensate for their wrist. If they can't get full extension of their back, maybe they're compensating. So you want to look at the flexibility all the way up their body to make sure that where that overextension is happening. With open growth plates, the growth plate is getting irritated, and so that is something that can be problematic and can cause growth disturbances. So these I treat in a cast, really just to try to get the kids and the family to understand the importance of it. And then I do switch them over to an Exos after a bit of time once they're calmed down. But again, this is a strength, a technique, a flexibility problem that is causing. So yes, it's an overload, but look at the problem why. So ulnar-sided joint pain in the wrist is hard. One of the things that we see, you have to be aware of is the anatomy of the DRUJ is pretty complex. There are various interosseous membranes. You've got your muscles crossing, tendons, but really the load of the joint is supposed to be mostly through the radius. And then there's some forgiveness with the ulna. If your load is off, then it's going to change the load on all of these structures. So one of the things that can cause a change in the load onto the ulnar side and the DRUJ is if you have a gymnast who has epiphysealysis of the distal radial growth plate, and it causes radial shortening. So if you have radial shortening, now you have a ulna positive joint, and you're going to load on that ulna more than the radius. So ulna positive, ulna negative are important to recognize. When we look at x-rays, there's lots of different ways you can measure them, but basically you're looking at the joint surface that is perpendicular to the axis of the bone. So if the ulna is longer then the joint surface of the radius, you've got ulnar positive. If it's shorter, you have ulnar negative. Typical is to have a little bit of shortening of the ulna compared to the radius. So what are the different causes of the variances? You can have a congenital where there's a partial deficiency of growth in the distal radius, and so it causes sort of a shape change of the radius. Most commonly, though, we'll see traumatic changes or growth arrest. And then, of course, you can have iatrogenic either on purpose to change the loading, or if you have to do something because of arthritis or something later that you're trying to unload that joint. So iatrogenic. Ulnar variants can lead to lots of different injuries. By putting a different load onto the ulna, you can get a TFCC tear. You can get ulnar abutment, which is really loading into the ulnar-sided carpal bones, can cause arthritis in any of those joints. And ulnar negative is more associated with Kienbach's and ulnar impingement syndrome. So when we are looking at x-rays, one of the things we're always looking at to look to see, how stable the fracture is or whatnot, you're trying to measure, I don't want to restart. You're trying to measure the DRUJ in terms of space, so width there, because if there is a tear of the interosseous membrane, you're going to have separation. You're going to look at ulnar height. Because when you have your distal radius fracture, you might have, so there's normally a small volar angulation of about 10 degrees. And if you have a fracture and it is a extended fracture, dorsally angulated, it's going to make the radius look shorter. So you might have an ulnar positive x-ray, which is telling you that there's actually some angulation of that fracture. So on x-rays, you want to look and see, space-wise, if there's widening of that DRUJ, that we really want to treat for that ligamentous injury. So we're going to brace it. You're going to try and get it into a position of stability. And if it's unstable, then you're going to refer. I'm not going to go through this chart in particular, but I do like this chart because it just gives you all the different all the different things to think about with ulnar-sided wrist pain. It's a frustrating problem because oftentimes you can't tell right in the first visit. You kind of have to keep understanding where they're pain, what's loading it, when they're having their pain. And so it takes a lot of history and just kind of following the patient. So TFCC, again, a seemingly small, easy, small piece of anatomy that is very complicated. There are lots of things that attach to it and can cause pain. It is very common to have a tear in your TFCC and not be generating pain. Because as you recall, this list is long. So when we get an MRI, we have to be careful about how we're interpreting it because you can have, just like any other piece of anatomy, you can have some change to it, but if it's not the pain generator, we're not going to treat it. So typically with the TFCC tear, you're going to have, a fallen outstretched hand, or you're going to have repetitive use that causes it. Typically, if you have ulnar pain with ulnar load and then supination or pronation, that's going to be a suggestion of TFCC tear causing as the generator of your pain. And then if you can reproduce the pain between the ulnar styloid and the triquetrum, that's another sign of a tear there. So imaging x-ray should look pretty normal unless you have a fracture. MRI, again, there's going to be a large percentage of people that are asymptomatic and that we wouldn't do anything with. So being mindful of what you're looking for when you get that MRI is very important. Acute tears, oftentimes we can treat them with anti-inflammatories and immobilization. If they have failed that, that's when we have surgical consideration. Carpal tunnel. So carpal tunnel, again, most of you that seen adults have probably already seen this. It's just remember it's, kind of sits in between the bony cradle with the flexor tendons, you have your median nerve, and then your aponeurosis or the transverse carpal ligament. This is a great thing to use ultrasound for, to identify, and you can, get a really good view of the median nerve. You can see the transverse ligament and all the different tendons. It's very helpful for injections um, to use imaging because, again, you don't want to go right into the nerve. Ideally, you would go around the nerve because you're not trying to injure it. You might see some loss of muscle mass in the thenar from loss of nerve stimulation there and kind of muscle wasting. Tinel sign, so tapping on the volar wrist. Phelan sign is, get tingling and electrical from compression, from flexion. And then the EMG looking at nerve conduction is sort of definitive testing to determine whether or not that's where it's coming from versus higher up. Definitely want to treat at the area it is. If it's coming from the elbow and you treat the wrist, that's obviously not going to help you. So initial treatment is using a wrist brace. I do really like this dorsal sided brace. It allows people to use their hand a little bit more. It's comfortable. And you can adjust the position so because this part is flexible. But any brace, I do have more at 24/7, especially at night. That's when people have a lot of symptoms. And then the injection, as I briefly talked about using ultrasound, is really nice. You can see that they're kind of activating their flexor tendon, so you can just go ulnar to that. And remember, in the wrist, people tend to think, kind of want to go too far out. Start proximally, and that's where having ultrasound can really help you so that you're going before the transverse carpal ligament. So then switching over to the other side, to the extensor compartment of the wrist, there are injuries that can occur to all the different ligaments. Knowing your compartments is important, knowing what's in them, and so that you can properly address them specifically is helpful. De Quervain's is tenosynovitis of the extensor tendon of the thumb. Finkelstein's test is, so you basically have them hug their thumb and then ulnarly deviate their hand. It's important when you do that you actually palpate along the extensors and the abductor palpus longus to see that that's where their pain is, because lots of things can be painful when you do that motion. And if it's not that tendon, then your injection isn't going to help. Again, this is somewhere that ultrasound is very helpful, although you don't need it. It's very helpful for the injection. When you are doing the injection, you want to make sure that you get it underneath the tendon sheath, and you should see it sort of fill up all along. I tend to try and do it along the abductor as well as along the extensor palpus, so that kind of angle it a little bit. But you really just want to see that sort of hot dog kind of fill up and know that you got it in there. Intersection syndrome is a little more proximal and a little more dorsal. So again, that's why you want to make sure when you're doing your test that you're palpating where the tendon where you expect it to be. If you do a Finkelstein's test and you're palpating and you're like, no, I'm not sore there, it's back further, that makes it very easy. It's the other thing that can be really easy about intersection is they often squeak. You can put your fingers on it and you can just sort of feel the crepitance of the tendon of them interaction with each other. And so again, brace, anti-inflammatory, and injection. All right, we are going to shift gears a little bit into different fractures of the hand and the wrist. So in general, when do we refer fractures? Any irreducible malrotated, if it's an intra-articular and it's displaced, anything that you reduce and can't stay, any open fracture, multiple fractures in the same hand, base of the fifth, most of those you're going to refer. Fractures involving more than 25% of the joint surface, except for the mallet finger, it's 30%. Scaphoid fracture, uh, impacted angulated distal radius fracture. So if there's a trauma and there's wrist pain, really need to remember to add the scaphoid view. It never hurts to have it, so it's better to have it than to not. If somebody comes in with outside films and they have radial sciatic wrist pain and they did not get a scaphoid, you must order a scaphoid. You can't just say, I have what I have and they didn't do it. It's on us to get it when we see them. And you want to make sure that the outside views are actually good views and not super rotated or it's always better to get appropriate views than to deal with non-appropriate. So distal radius is the most common wrist fracture. It's many times is non-operative. You want to make sure and you check that snuff box for the scaphoid injury. And you also want to check the radial head. Remember, when we load the joint, most of the load goes through the carpal bones to the distal radius, up the radius to the other end. So even though a lot of times the pressure dissipates through the radial distal radius, you can have multiple fractures. So you want to make sure you have at least 3 views of the wrist and a view of the scaphoid. And recheck if there's tenderness in the snuff box, you want to repeat an x-ray in 7 days. Generally, if you have any clinical concern that they have a scaphoid fracture, you treat them as such and you bring them back in 7 days. I treated a friend's kid who came in and I was sure he had a scaphoid fracture. I put him, I thought he was reliable. His parents are reliable. I put him in a brace and I said, come back in a week. Well, he felt great in the brace. So he, kept on going, took the brace off after a week and came back about 4 weeks later with a very visible scaphoid fracture that then required surgery. And he did okay, but it would have been much easier if we had just treated him initially in a cast, then he would have had to have come back. So that is really the reason for the cast is reliability and just making sure that you don't miss it if you really think clinically it's a scaphoid fracture. So I need to move this to a different place in the talk, I can tell, because it would have been helpful when I was trying to explain how to measure ulnar variance. So when we're looking at these x-rays, what we're visually measuring is the radial inclination. It's about 20, 22 degrees. More than that, of course, shows that there's been some change to the bone or a congenital change, or less than that. Radial shortening. So again, you want to take the length of the bone and then 90 degrees, and you're going to have the distal and then the proximal sides, and then measure that compared with this line is the ulnar length. And so this is the ulnar variance in between here. And then I was talking about the volar tilt. So if you have, I always think of 10 degrees, this shows 11. If it's typically volar tilt of 11 degrees and you have a fracture that brings this dorsal aspect down, so now you're neutral, that's actually displaced. Usually within 10 degrees is fine. But if you have 10 degrees dorsal angulation, that's 20 degrees dorsal angulation, because you have to add that 10 degrees plus the 10 degrees. So these are things that we need to consider when we're trying to recreate normal anatomy when we're treating them. So when you look at this x-ray, we can see this line right here is the dorsal aspect of our distal radius. You can't really see the other side, but look, it's shorter than the ulna. I know right on this that it's going to be either impacted or dorsally angulated. And in this case, it's, the fracture is pushed down on both sides. So radial shortening here needs to be needs to be brought back out to length. And that is because this is a comminuted fracture that needs to be surgically fixed. So, and you're looking for angulation of the distal fragment, and then depending on their age is how much you would accept. In a young person, they're gonna lose motion and they're gonna have long-term arthritic complications if you don't get that angulation and display and the length back out. So what do we do when we're reducing them? if you see somebody with a fresh fracture, there's a big hematoma there. And if you can just take, you can just go in and inject lidocaine into the hematoma, but it's much more effective if you take the blood out. So ideally, you want to have them so that their wrist is above, so that when you put your needle in with your lidocaine into the hematoma, you can actually draw back the blood and it will, it'll sink to the lidocaine will go to the top, and then you can inject the lidocaine and using the same needle and not have to do that. So it's nice because you can actually get more lidocaine in there rather than diluting it into the bloody hematoma. I've done that a couple times when it's worked well. Most of the time, I just actually inject right the lidocaine in there and just simply do that. But hematoma blocks can be very helpful. So when you're reducing things in office. And then as we talked about with the dislocations, recreate the deformity, apply traction, and reduce aggressively. This is not a time to be like, do. You want to make sure whoever is applying traction is, has their elbow and is holding it really well. So I oftentimes like really kind of use my legs and pull up and reduce it. So that you don't have to do it multiple times. You should feel it reduce. Once it's reduced, you want to go ahead and put a well-fit sugar tone splint on, get a post-reduction film, and then weekly x-rays to make sure the alignment remains. You can change, if somebody comes in with a sugar tongue on, I will generally make it into a long arm cast. I'll have the cast tech override it. And then at 3 weeks, I will change them to a short arm. Comminuted distal radius fractures are surgical referral. If you are referring and you have time, you can get a CT scan with thin axial cuts. It helps with surgical planning, but you just ask the surgeon what they want so that we can, help facilitate that. Also, before you go through all the effort, make sure they're a surgical candidate. If they're a much elderly person, they have dementia, they have medical issues, they may not be a surgical candidate. Unfortunately, in today's world, if they don't have insurance, I had a patient, actually was a young patient, but was from a different country and knows insurance in our country, and was very, very, very difficult to get assistance with. So kind of do a little bit of footwork up front. It saves time down the line. So carpal bones, there's 8 of them. Everyone has a different mnemonic. So long to pinky, here come the thumb. It's not the one I learned in med school, but I couldn't remember what it was. It obviously didn't work for me. Got to look for scaphoid fractures, right? If you have a fallen out stretched hand in a kind of youngest person, they may or may not have that distal radius or radial head. Anytime there's a foosh, you want to make sure, we talked about this, protect them. I put them in a cast and bring them back. The splint, I've been burned, so you've heard my story. If you really think that they have it, go ahead and get an MRI. The problem with missed scaphoid fractures is you can get collapse because basically the blood supply to the scaphoid, it comes in distally and back. And so if you don't treat it and it loses the blood supply, that bone kind of dies, and then you get carpal collapse, which causes pretty significant loss of motion and pain, not that long out after you had the injury. Surgical referral. So non-displaced scaphoids can still be treated surgically. It does expedite your return. So for example, a surgeon that needs their hand might choose to have surgery because they can return earlier. Certain athletes might. It is a small screw that goes in there. So you are having surgery, you do have stiffness, but they do well. And then, of course, if there's an unstable fracture or there's any sort of displacement, then they're going to probably have lots of blood supply that can cause problems. It's better to treat them surgically early on. For non-surgical treatment, short arm thumb spica IP free is good. There have been studies done that don't show any difference between short versus long arm. It's a little bit of a personal preference. I use a short arm. And then you want to cast until they're clinically and radiographically healed. For if you are looking and just trying to decide further imaging, an MRI is useful if you don't know whether or not they have one because of the edema associated. If you know they have one and you're really just looking to see more the extent of it and whether or not there's any separation or malalignment, then you want to get a CT scan with thin axial cuts through the scaphoid. So axial of the scaphoid. And you just write that down on your order. Hook a hamate fracture. This is more common in anyone that's using a bat or a stick. Often it's like ulnar-sided wrist pain that's kind of vague. It can be from overuse, but it's also oftentimes from trauma. So if you ulnar deviate the wrist and then resist the pulling on the flexed ring and pinky fingers, that pulls on that hook hamate and can cause pain and suggest a fracture. Of course, direct pressure can suggest a fracture. And these are, not super necessary bones, so you can just excise it. So again, if they're having pain and they fit the picture, go ahead and get further imaging with a MRI. And then if they are not healing, that's a surgical referral. How are we doing on time? I think I'm pretty close to being done. So we have a few more minutes. I'll try and get you guys out of here soon. So we talked a little bit about making sure you had a good x-ray. You want to make sure your condyles are aligned. So there it is. Here you can see that these condyles are not aligned. So it looks like there's a V sign here. You've got sort of widening here, but that's really just because it's not a perfect lateral. So you want to just repeat the lateral to make sure you get a good view. So 30% of all hand fractures are metacarpal fractures. When you're looking at them, you want to make sure that you kind of make a fist, look at the metacarpal heads. You don't want any of them to be more than 5 millimeters shorter. That suggests shortening of the metacarpal. Malrotation, you want to make sure that when you are bending the hand down towards a fist, that they all are flexed towards and point towards the scaphoid. And then when you look at an x-ray of the hand, you should really have alignment of the line going straight through the metacarpal and out through the phalanxes. So when your hands are extended, you want to make sure that there's no angulation from those. When you have fractures, you want to define the fracture whether it's transverse, so straight across. These are common, and if they're angulated, they are unstable. If they are non-angulated, they tend to be pretty stable. Oblique or spiral fracture, you want to make sure that there's no rotation or shortening. And if there is, you need to refer. If there's any comminution, you need to refer. And then what we would consider a boxer fracture on the fifth, so a neck fracture, you're going to refer those if they have any angulation on the index finger or the long finger. But the other ones, the fourth and fifth, are very forgiving. You can have a significant angulation and still have great strength, grip strength, and function. So assuming there's no rotation or angulation, we are going to treat metacarpal fractures and phalangeal fractures in this sort of gauntlet type, although that term means something else. So a cast with your MCPs flexed to 90 degrees and your wrist extended. This is called the safe position because it's taking the pressure of the tendons and ligaments off of the joints so that you're not having any pull. And also it keeps you so that when you get out of this cast, you are not fighting to get your flexion range of motion back. So generally I would do 2 weeks for sure. Depending on the type of fracture it is, I would do maybe all 4 weeks in a cast versus using the exos. And then protect them with buddy loops for a couple of weeks while they're getting their range of motion back. So this is just another view of the safe position to, relieving the lumbricals pressure off of it. Boxer fracture, these are very forgiving, and really, unless there's more than 30 to 40 degrees angulation, you don't really have to do much. A lot of times, if you reduce them, they continue to be problematic, meaning that you don't get very good reduction on them. However, reduction is done, as is shown below, you actually flex the MCP and flex the PIP, and then you use that force of the proximal phalanx to help you reduce it. So you're, really sort of that your load is forced through that finger. And then that's important too, that when you're treating them, that you keep them flexed at 90 degrees so that it has that angular support and the safe position. So boxers cast 3 to 4 weeks and the safe position, and then buddy loops. And then I return them pretty quickly as soon as they're comfortable. So 4 to 6 weeks. Who do we refer? So we talked about angulation. This is a good way when you're looking at flex fingers pointing towards the scaphoid. You can see that this one's off versus having them all kind of coming down to this area. We talked about this in the general thing, but anything unstable, shortened, malrotated, comminuted, oblique, or transverse midshaft, those we need to be referred. This is a picture of the lumbricals pulling and making something. So even though if you were to reduce that, it's going to keep going like that. So if you put them in the safe position, you flex the finger, it takes some of the pressure off of that. So you may be able to keep that extended, but because of the location of this one, it's probably not going to be. All right, we talked about that. All right, base of the thumb metacarpal fractures. So Bennett or Rolando fracture, a Bennett fracture is an intra-articular fracture as well. Rolando is more of a Y-shaped one, and Bennett is just sort of through it. There are certain views you can get to get the base of the fifth and the base of the thumb. And if you ask your X-ray tech, just say, I think the base of the fifth is like the ball catcher. And then the thumb one, I just tell them, get a good view of that. So you can see how much the joint is involved. If these involve the joint, you really want to refer them to the surgeon. Phalanx fractures, I was just briefly talking about the proximal midshaft fracture, and that it's pulled into flexion because of the muscles. That we want to send these off. The middle phalanx, depending on where it is, where the fracture is, you're going to get flexion from the FDS where it pulls. And so you're going to get pulled into flexion. And then if it's distal to that, they tend to do a little bit better. Most phalanx fractures, if they're outside the joint, they don't have shortening or angulation. You can treat, and I do, because I see mostly kids, I will put them in exos for protection, but you can also treat them in buddy loops. So we are really lucky that we have these ulnar and radial gutter. So I use those, and then after 2 weeks, 2-3 weeks, I will switch them over to buddy loops. And if you don't have buddy loops, just use tape. Distal phalanx fractures, most of these do really well. But again, check the nail bed. You may need to put in a piece of foil or something into the nail bed to maintain it. Of note, distal phalanx fractures are really, really painful. A lot of times it's because they have bleeding in this area or under the nail. So if it, like I said, if it's under the nail, release the pressure. It helps so much. So a distal phalanx fracture in pediatrics, though, is different. So that Seymour fracture, that generally is a fracture of the nail bed and is an open fracture. So these need to be referred to a surgeon. Let me see how we're doing. Oops. I somehow stopped sharing my screen, but I will get you guys back there. I think that's it. Actually, I had one slide left, but I stopped sharing, so I will skip it. That was a lot. Any questions? Is anyone still there?
Yes, this was really helpful. Thank you.
I will.
That was great, Laura. That's you guys. That's about all you need to know about fingers and hand. Seriously.
I tried to make it a little bit more clear and I rearranged some things and I realized when I rearranged it, I was like, wait a minute. So I think that I have to go back and rearrange some things again. Um, but it's a lot of shit. So anyhow, thanks guys.
It is a lot, but your slides are fantastic. You guys just like this was for the fellows when you guys are giving talks. Like this was a good example of not having too much crap on your slides. And just having pictures that explain everything, I think makes it easier for everyone. So this is a good one to go back and look at when you are starting to make your own things so that you can, like, there should be no paragraphs on your slides. You should also never say the words, I know this is a busy slide, but no, if it's a busy slide, don't use it. Like Laura had that one table, it wasn't busy, it was very easy to look at, and she also didn't read it to you. Like, I think this was just a well done talk. That's a good example for you guys.
Thank you. I am dying today. I have a cold and I'm going straight into pediatric interviews. I can't wait.
Well, that was dumb of you to volunteer for those.
After like the 50th request, I was like, all right, I will do it. So check.
I did it for probably the first 6 years I was there. And then I was like, why am I doing this and fellowship interviews? This is so terrible.
I know. I'm like, okay. Oh, well, you guys have a good Halloween. We'll see you all soon.